Perfect. So I'm Parth, I'm one of the other reps for paramedics. So this talk is going to be, it's part 2 of our child series, where we go from antenatal down to birth, down to peds. So part 2 involves bleeding and pregnancy, and I've touched a bit on pain as well. So what in terms of learning objectives, I've got being able to distinguish the causes and differential diagnosis of early pregnancy bleeding and late pregnancy bleeding, being able to formulate a list of investigations that may be required for some of the causes of bleeding in pregnancy, and understanding the management of the common causes of bleeding in pregnancy. So the way I like to do my teaching is just to do it case-based, and then we'll go through each of the answers and the main topic at hand, just so you guys are more involved and you understand a bit about how questions can be asked in exams and common presentations and things like that. So case 1, it's a 19-year-old woman who presents with a 2-day history of central lower abdominal pain, which was relieved with analgesia, and 1-day history of vaginal bleeding. Her last period was 8 weeks ago, and she had a beta HCG level of 2000. On examination, her cervix is tended to touch. What's the most likely diagnosis? Is it A, ectopic pregnancy, B, threatened miscarriage, C, delayed miscarriage, or D, an inevitable miscarriage? Ollie, you got a poll up?
All right, guys, you should see a poll on your screens. Can you see?
Okay, perfect. So I think everyone chose A, which is ectopic pregnancy, which is the right answer. So in terms of an ectopic pregnancy, the general symptoms are low abdominal pain, which is generally the first symptom, and it's key for ectopic pregnancy. Is generally unilateral because it affects the adnexy and the fallopian tube. So it's when there's abnormal implantation of the embryo. So the embryo will either implant in the tube or implant in the ovary, and that's why it's unilateral, because you only get one egg release at a time. And then you can get shoulder tip pain, which is referred pain from the irritation from the ectopic implantation, and it will irritate the diaphragm, which the phrenic nerve innervates, so you get shoulder tip pain, and vaginal bleeding. So if we go back to the case, you can see that her cervix was tender to touch, which is generally what we call either cervical excitation, or I feel like there's another term, but I just use cervical excitation. And there's other causes of cervical excitation as well. I don't know if you can put in the chat if you know of any other causes of cervical excitation. Yeah, so the main one that everyone's put is PID. PID is one of the main causes of cervical excitation, and generally they do it in people who are suspected PID to rule out appendicitis, because appendicitis can also be a differential with someone presenting with symptoms similar to PID. So that's generally just the gist of ectopic pregnancy, and we're going to move on to the management of it in the next bit. But in terms of assessing whether someone has got an ectopic pregnancy, the first sign is generally a transvaginal ultrasound, which is an ultrasound probe through the vagina to assess the uterus and the walls, the uterine walls and the ovaries that are present, which is more accurate than the use of a transabdominal ultrasound. So they use the transvaginal more often. So continuing with the case, so a transvaginal ultrasound was arranged for this woman as an outpatient within the next day, and the ultrasound revealed an adnexal mass of 30 millimeters and no evidence of a viable intrauterine pregnancy. So a repeat beta HCG was performed and it revealed a level of 1,008, well, that's meant to say 1,450, sorry. What would be the best management for this patient? Is it A, expectant management, B, methotrexate, C, misoprostol, or D, a salpingectomy?
I'll just give a few more seconds.
Okay, so a bit of a mixed bag there. So those who said methotrexate, you're in fact correct. So the reason is, if we just go through it, so I've got a bit of a slide here in terms of the management of ectopic pregnancy. So expectant management is to wait for a spontaneous abortions, to wait for the I don't know how to say it, the mass to pass, basically. And expectant management isn't generally advised in ectopic pregnancy. It can be offered, but it's not the mainstay because of the fact that it's implanted within the adnexate, so it will be harder for it to pass normally compared to something like an intrauterine pregnancy. So I would kind of rule out A. In terms of methotrexate, that's the correct answer, and that's the medical treatment of trying to remove an adnexal mass. Misoprostol is a vaginal prostaglandin, which is generally used to contract the uterus to cause ejection of something within the uterus. So we'll go on to that in further cases. And a salpingectomy is the surgical management of a ruptured ectopic pregnancy. So if we go down here, you can see that medical management is reserved for an ectopic pregnancy where the size is less than 35 millimeters, which will be identified on the transvaginal scan, an unruptured ectopic pregnancy. So an unruptured ectopic pregnancy is easily identifiable because if someone's got a ruptured ectopic pregnancy, they would be very unwell. They'd be systemically unwell, they'd be in shock, they would be bleeding a lot. It's just quite obvious to know if something's ruptured. And then that's immediate surgery. And it's a surgical emergency because of the amount of blood you can lose when an ectopic pregnancy ruptures. Medical management, something key is no significant pain and a beta HCG of less than 1500. So for it to be managed medically, you don't just need one of these, you need all four of these for it to be managed medically. If they have, say, a 30 millimeter unruptured adnexal mass and a beta HCG of 1400, but they're in a lot of pain, you wouldn't go medically because pain is indicated for surgical management. So just one of these being different would cause it to be a surgical management. The only one that's an exception is beta HCG. If the beta HCG is between 1500 to 5000, you'd offer the patient whether they want medical or surgical. I hope that's all right. Any questions at this point? No? Okay. So case 2, it's a 27-year-old preemie woman who presents to the obstetric team at 12 weeks with a 3-day history of lower abdominal pain and mild bleeding from her vagina with clots. Her vital signs are stable and a speculum reveals an open cervical os. On assessment of her vital signs, her temperature is noted to be 37.9 degrees. What's the most likely diagnosis? A, a threatened miscarriage, B, a delayed miscarriage, C, an inevitable miscarriage, or D, an incomplete miscarriage? So a lot of people went for threatened miscarriage. So in the answer actually is an incomplete miscarriage. And the reason is basically I've done again another nice table to show you the types of miscarriages and how they present. So the reason this one is an incomplete miscarriage, one is because of the open cervical loss, the bleeding and pain. But what distinguishes it from the key one, which is the inevitable miscarriage, is that there's the presence of clots. So the presence of clots shows that they're starting to pass the products of conception. And because of that, you'd think it's an incomplete miscarriage because not all has passed. An inevitable miscarriage would only be a heavy bleeding with pain and no evidence of clots. Threatened miscarriage is a closed cervical loss compared to inevitable and incomplete, where it would be open. So the reason is it's threatened. So there's a chance for the mother to miscarry, which is why it's threatened, but they haven't miscarried yet, which is why the cervical loss is not open, so it's closed. That's why it's called threatened. They generally get painless vaginal bleeding, and it's generally a very early first trimester thing, so it happens within 6 to 9 weeks before maybe the mother knows she's pregnant, or before they go to the booking scan, they would have a threatened miscarriage. Yeah, and that's it. So the next bit. So this woman who's had the incomplete miscarriage has had a transabdominal ultrasound now performed, and it's identified to have no fetal heartbeat and some retained products of conception. What's the best management option for this patient? Is it A, dilation and curettage, B, vaginal misoprostol, C, oral mifepristone and vaginal misoprostol, or D, expected management?
Just a few seconds more. See, 10, 15 seconds.
Okay. So it seems as if there's been a mix between vaginal misoprostol and oral mifepristone and vaginal misoprostol. So the answer is vaginal misoprostol. So if we go to miscarriage management, so if you look at this patient, generally in the management of a miscarriage, the first line is expected management, so waiting for a spontaneous miscarriage to happen. So you'd wait 7 to 14 days for a miscarriage to happen. That's generally if they've got either an inevitable or an incomplete miscarriage. You'd wait 7 to 14 days for a spontaneous miscarriage to happen. Medical management, such as in this patient, and I'll explain why, would only be vaginal misoprostol, and that's recommended by NICE. I understand why people might have put oral mifepristone and vaginal misoprostol, but even though they use that in different countries, it's not recommended by NICE in use of this country, so they generally only go for vaginal misoprostol. And the reason they do that is if it's a late first trimester miscarriage, if there's evidence of infection, if they've got history of recurrent miscarriages or risk of hemorrhage. So this patient, if we go back, she's 12 weeks. And if you know your trimesters, 12 weeks is basically at the end of her first trimester. And miscarriages, if they were to happen earlier, around 6 to 10 weeks. So because of the fact that it's late first trimester, you'd want to medically manage it, and that's vaginal misoprostol. She's also got potential sign of infection because of 37.9, but that's borderline. So in terms of her having, maybe a patient having recurrent miscarriages, does anyone know of risk factors of patients having recurrent miscarriages, particularly one syndrome? Yeah, antiphospholipid syndrome, the patient would have recurrent miscarriages. And risk of hemorrhage, those would be clotting disorders and things like that. So surgical management is generally the last form of management, and that would be a vacuum aspiration or surgical removal. So case 3, it's a 31-year-old woman who presents with painless vaginal bleeding at 15 weeks. She's not yet had any antenatal care despite suffering from severe vomiting and some painless vaginal bleeding. On examination, the uterus is very large for her gestation. What's the likely diagnosis? Is it A, an ectopic pregnancy, B, a threatened miscarriage, C, fibroids, or D, a hydatid form mole?
A few seconds more, guys.
Okay, so again, a bit of a mixed bag, but people have gone for hydatid form mole, and that's the correct answer. So I saw someone went for threatened miscarriage and someone went for fibroids. So painless vaginal bleeding, yes, possible threatened miscarriage. 15 weeks, maybe rules likely against it. Threatened miscarriage, like I said, generally happens between 6 to 10 weeks, but can happen up to 24 weeks. So yes, maybe. And something that rules against it is the fact that her uterus is really large for her gestation. If you're miscarrying, your uterus wouldn't generally be large because you're potentially losing a fetus. So the fact that it's potentially large kind of goes against the threatened miscarriage. Someone put fibroids, yes, they could be, but she would have pain. Fibroids generally is a cause of pain, pelvic pain, so it wouldn't be painless. Hydatidform mole is the correct answer, and molar pregnancies, I just like to say molar pregnancies because it's easier, can generally be split up into two, a complete mole or a partial mole. So a complete mole is benign tumor of trophoblastic material, and it's when an empty egg with no chromosomal material is fertilized by a single sperm, which then duplicates its DNA. So you get 46YY, and all the chromosomes will be paternal. So that's a complete molar pregnancy, and those are generally more commonly seen. A partial molar pregnancy is when there's a normal haploid egg, so it's got X chromosome in it, and that can be fertilized with 2 sperm. So then you'd have both maternal and paternal chromosomes. So that's generally what a molar pregnancy is. And if we look at like the investigations for a molar pregnancy, you generally want to do transvaginal ultrasound and see it. And as you can see in this patient, she had some vaginal bleeding, which is a sign of molar pregnancy. But another common, really big sign of molar pregnancy that will give it away is severe vomiting. So hyperemesis is another clear sign that she may have a molar pregnancy if she's got hyperemesis, and a very large uterus. So 3 signs of molar pregnancy that kind of distinct to it are hyperemesis, large uterus, so basically uterus that's bigger than her gestation, and some vaginal bleeding. And then when you think about investigations, another thing that would be diagnostic for molar pregnancy is you'd get on transvaginal ultrasound, I don't know if you can see it from here, but these little pockets, which are basically small spaces where the little masses are, and they form really small spaces. That's basically what the molar pregnancy is. And a hugely elevated beta HCG. So those two, in addition to the 3 symptoms, would be diagnostic of a molar pregnancy. So now that we've gone through that, what would be the best management for this patient, considering her diagnosis? Is it A, suction curettage, B, a vaginal misoprostol, C, oral mifepristone, and D, hysterectomy?
Just a few seconds more.
Okay, so again, another mixed bag of suction curettage or oral mifepristone. So the answer is suction curettage, and generally for molar pregnancy, you'd want to go for suction curettage. That's the first line. Medical management wouldn't be an oral mifepristone, it would be misoprostol, and is not generally advised but can be used. Suction curettage is generally the first line, and you wouldn't want to do a hysterectomy because if it can easily be removed. So in terms of just summing up early pregnancy bleeding, these are like the common differential diagnosis: a potential miscarriage, ectopic pregnancy, implantation bleeding. Generally, implantation bleeding is a diagnosis of exclusion. So you want to rule out miscarriage, ectopic pregnancy, potential molar pregnancy, any other gynecological conditions that could be causing it, such as a cervical ectropion. So when you do a speculum, you'd be able to see this. Could you see a red patches on the external os of the cervix, which would lead to a diagnosis of cervical ectropion. Vaginitis, which would be tenderness within the basically an inflammation of the vagina. Trauma, and polyps. So those are the differential diagnoses. So case 4 is a 32-year-old primiparous woman who presents with painless vaginal bleeding at 18 weeks gestation. She's not yet had her anomaly scan, and so it was done during this appointment. It was identified that she had a low-lying placenta. So what should be done next? A, induce a medical termination. B, do serial scans every 2 weeks. C, repeat her scan at 28 weeks. Or D, repeat her scan at 32 weeks. So I think the most popular answer was serial scans. But the actual answer is repeating her scan at 32 weeks. I don't know why. I understand maybe why people put serial scans, because you just want to make sure that the placenta isn't dropping down, or you want to just reassure the patient. But I think with something like a low-lying placenta, they are common within pregnant patients. So serially scanning them every 2 weeks may not make a difference in terms of the placental position. So waiting until 32 weeks is generally guideline standards to see if it's progressed to something like you call placenta previa. If it's progressed to that, you'd want to wait till 32 weeks, because that's when you do some sort of intervention or some sort of planning. 28 weeks would be a bit too early, unless there are huge risk factors, or unless she's had more risks of bleeding. That's when you do more interventions such as scanning, and you wouldn't do a induced medical termination. So a repeat scan was performed at 32 weeks and the lower edge of the placenta was found to be reaching the internal os. Hence, she was diagnosed with placenta previa. Since then, she's had repeating bleeding episodes and is currently 34 weeks with another bleeding episode. So she's basically had multiple bleeding episodes apart from the initial one, and now is having one, and she's 34 weeks. So she's got a bleeding episode and she's in MAU, so the maternity assessment unit. What should be done next? Would you A, induce and deliver the baby vaginally? Would you B, do an emergency cesarean section? Would you C, admit and observe the patient until delivery? Or D, would you admit and observe and then discharge her with a planned delivery? So it seems like people have gone for D, which is good because which isn't good, sorry. The answer is actually C. So I understand why people went for D, which is admit and observe, then discharge with a planned delivery. That generally, if you think about the case as a whole, okay, so if we talk about initially, so she had a low-lying placenta, what should be done next? And then she came back for a 32-week scan and she was found to have placenta previa. If that was it, at that point, what you would want to do is at 32 weeks, you'd want to make a plan with the patient if she's been diagnosed with placenta previa about what's going to be done next. So generally with placenta previa, it's a cesarean section. So at 32 weeks, if she's been diagnosed, you want to make a plan of when she's going to have her elective cesarean section. So that would be done then, and then she could be sent home during her outpatient stay. But she's then had repeated bleeding episodes, and she's now 34 weeks and still having these bleeding episodes. Because of this recurrent bleeding, you'd want to admit and observe her, yes. And then it comes down to, would you discharge her with her already planned cesarean, or would you wait and keep her as an inpatient till her delivery? And you'd want to keep her in until her delivery. And the reason is because of these recurrent bleeding episodes, because of the fact that she may be high risk because of this recurrent bleeding, and there could be potential, not malformations, I want to say, because that's a bit of a weird word, but there's just a risk. You'd want to keep and observe her, because then you could intervene at any point if something happens, like fetal distress, or if there's maternal distress, or if her observations go off the chart, then you can intervene straight away. So that's better than discharging her at this point because you've got a history of bleeding. So like I said, with placenta previa, it's third trimester bleeding generally, and you diagnose it at 32 weeks. Prior to 32 weeks, you just class it as a low-lying placenta, and then you diagnose it at 32 weeks. And risk factors for placenta previa would be something like multiparity if they've had multiple pregnancies. Multiple pregnancy just means a twin pregnancy, and a previous C-section, because the placenta will then implant on the cesarean section scar. And you can see here how they grade the placenta previa based on where the placenta is. So this woman had a lower edge reaching the internal os, so this one, so it's a marginal previa, but they don't generally use these terms anymore. So in terms of planning a cesarean section in a woman with placenta previa, the dates do differ between different trusts and things like that, but generally, when I was at the women's, the consultant I was with told me that they always plan it for 36 to 37 weeks, just because of studies and something like that. So I just go with 36 to 37 weeks. So this is the last case. It's a 7 department after having severe lower abdominal pain and vaginal bleeding. She's recently been treated for gonorrhea with ceftriaxone, and she takes no regular medications, but she admits to illicit drug use with marijuana, and cocaine. You palpate her abdomen to find her uterus hard and tender. What's the diagnosis? Is it A, placenta previa, B, placenta accreta, C, incomplete miscarriage, or D, a placental abruption?
Just a few more seconds, guys, and then we'll wrap things up.
Okay, so it's one of everything basically. So if we go through it, oh. We love nice last minute. But yeah, so if we go through it in terms of just the case, so the answer actually is a placental abruption. So if we think of placenta previa, as I said, generally it's diagnosed at 32 weeks in its third trimester. So she wouldn't have placenta previa at 23 weeks. Incomplete miscarriage, like I said, she'd be passing clots, and it's generally less than 20 weeks. So it wouldn't be an incomplete miscarriage. So then you're left with placenta accreta or a placental abruption. And something that gives away it being a placental abruption is the fact that she is an illicit drug user with cocaine. So what cocaine is it is a obviously a drug, but it causes vasospasm of the uterus. And by causing vasospasm of the uterus, what you're doing is you're causing the placenta to basically rip off of imagine this is the uterus, this hand is the uterus, and that's the placenta. By causing vasospasm of the uterus, you're causing the placenta to generally move off. And that's generally what an abruption is. And you can have two types of abruptions, a revealed abruption and a concealed abruption. A concealed abruption would be, say it moves off and there's blood here and it collects at the back. That's a concealed abruption. A revealed abruption would be there's blood, but it trickles down, and that's why you get the bleeding, and that's what placental abruption is. So the cocaine use generally basically gives an indication to what the diagnosis is for this case, if that makes sense. And I think that's it. Does anyone have any questions at this point, or?
Yeah, guys, if you have questions, feel free. If you don't want to turn your cameras on, just pop it into the chat, and Parth will answer. I'll also be putting a link in the chat to the survey, so we'd be really grateful if you guys could fill that. I'll just pop that in now. And if everyone just tells me if they can click on it and if it takes them to the right website, that would be great. But yeah, please feel free to ask any questions that you might have.
Yeah, sorry, I didn't. Yeah, a hard, firm uterus. Well, it's a hard and tender uterus. That's indicative of a placental abruption. Does anyone have any other questions?
Nothing yet. Thanks for coming, guys. Obviously, feel free to ask any questions, and if you'd like to leave as well, then that's fine. Don't forget to fill the survey, and we'll be here to answer any questions you might have. So you can just stay or leave or whatever. Oh, you're welcome. Okay, I'm going to stop recording now.